So could you tell us broadly what your research interests are?
Thank you for your question. Generally, broadly, I'm interested in child developmental disorders, including autism and intellectual disability. And also, I'm interested in the well-being and mental health of women and children in general. My background is in social anthropology, so I'm also interested in the cultural aspects of these issues.
Thanks, Mel. My background is in autism research. So I started working on autism research in high-income countries, initially in the Netherlands and then in the UK. But sort of later in my career, about 10 years ago, I became increasingly aware of the gap in autism research, how almost everything we know about autism, what causes it, what interventions might work, are based on research in high-income Western countries, mostly North America and Europe. And I became involved in working in Ethiopia through an education project. So initially this wasn't related to my research. Loved Ethiopia as a country and really felt working in this type of context would be much more meaningful for me. And it feels like this would really address a gap in what we currently know about autism. And I would really like to spend more of my efforts studying autism in low resource context and developing intervention solutions that address the unmet needs for families. So most of my work now is in Ethiopia. In a new project, we also start working in Kenya. My work has also broadened to not just be about autism, but be about developmental disorders more broadly. And that is really in the recognition that in the context where we work, so in low resource, low awareness settings where there is pretty much no specialist help available, it doesn't really make sense to focus only on autism. The kids that we identify typically have autism and intellectual disability, are mostly nonverbal. And the challenges experienced by families with kids with developmental disorders only, with intellectual disability only and no autism, or kids with autism and intellectual disability, at the moment, those challenges are very similar. So it makes more sense to address them in a wider group of developmental disorders and delays, instead of singling out and saying, I'm only going to help you because your child happens to also have autism. So that's the context.
Wonderful. And this question is for Beth. What led you to focus your research on Ethiopia?
I was born and raised in Addis Ababa, Ethiopia. So naturally, I'm very interested to change and if I can help the situation in Ethiopia regarding child developmental disorders. There is high level of stigma surrounding this issue. So I'm motivated, partly I'm motivated because I was born and raised in Ethiopia.
Great. And could you tell our CRAE audience what the research that you presented today is about?
Today, I presented about stigma, particularly based on our qualitative study on the perceptions and experiences of stigma among parents, both in Addis Ababa, that is the capital city of Ethiopia, and in the rural town of Butajira. So that was the focus of my presentation today.
And followed on from Beth. So Beth sort of sketched the Ethiopian context and the main challenge of stigma. And my part of the talk focused on interventions that we have developed and evaluated to try address some of these needs. So to raise awareness in the community, we created an intervention to a training for community health workers who work in rural Ethiopia to improve their knowledge and awareness and address their stigmatizing beliefs and attitudes towards families with kids with developmental disorders. That was the Heat Plus project, so I talked about that. And I also talked about an important big new development led by the World Health Organization. They have developed a program, the Caregiver Skills Training Program, to support caregivers of kids with developmental disorders and train them to learn strategies that help them support their child's development and behaviors. And the WHO is currently working with teams in 30 countries across the world to adapt and test the program. We became involved with WHO early. So we were able to give them early feedback on their work. We've adapted the program for use in Ethiopia and tested it and piloted it. So I presented some of those findings that are overall really promising. Families really like the program. They are highly engaged. They are really happy that there is finally some type of support for them. But that also highlighted some of the challenges, because ideally we would like this program to work also in remote rural context where there are no specialists available. And for that to happen and for that to be more sustainably implemented in a system and make sure that children are also referred to relevant health services, that kids have access to education, more needs to happen. But we were very lucky to receive funding from NIHR to work together with a team in Kenya led by Amina Abubakar to do a new study for 4 years called the SPARK project. So in SPARK, we will have time to really look into this in more detail. So we will do a large randomized controlled trial of the caregiver skills training, but we will also try address those additional issues. So to make sure that the caregiver skills training is embedded in a wider health and education support system.
That sounds wonderful. And just one last question. What are the main results of your research that you presented today, and what do you think are the implications of this research?
The main findings of the study I presented today is that parents experienced various kinds of stigma. They perceived and experienced different forms of stigma. For example, stigma that was directed towards their child, stigma that was directed towards the parents themselves, and also some parents isolated themselves and their child from social life. The other finding is that parents experienced the negative consequences of stigma. They perceived the negative consequences of stigma not only on their child with developmental disorder, but also on themselves and then on their siblings. Parents also talked about the positive social experiences. They said, for example, they were supported by their family. They received support from their neighbors. They received support generally from the public. And the other main finding was that not all parents who experienced and perceived stigma went on to internalize the stigma. There were contributing and protective factors. And one of the contributing factor for internalized stigma was lack of support and acceptance from their family. Parents who said they didn't get support and they were not accepted by their family reported, for example, feelings of shame and self-blame, and they withdrew themselves and their child from social life. And on the other hand, parents who said they received support and acceptance from their family, they said even if they experienced stigma, they didn't feel embarrassed or ashamed, and they went on, doing their normal activities, like they were engaging in social life, both themselves and their child. In terms of implications of our findings, some of the implications of our findings are, for example, we need to have awareness-raising activities that target the community to tackle stigma, and also awareness-raising activities that targets the parents themselves, and also interventions needs to focus on not only on individuals but generally as a family unit, because negative consequences of stigma were felt not only on the child but also siblings and the parents themselves. And larger social structural issues like tackling poverty is also important, because some parents, particularly single mothers, were experiencing multiple and intersecting challenges. In addition to stigma and social isolation, they were experiencing poverty and the challenges that come with being a single parent.
And so I discussed some of the interventions that came about after realizing the unmet needs and the challenges of these families. So in our HEAT Plus project, where we trained health extension workers, so community health workers working in rural Ethiopia, and provided them with some basic education about developmental disorders, we found that short training was effective in reducing the negative beliefs and stigmatizing attitudes towards kids with developmental disorders. But there was also an unintended consequence of those health extension workers who were trained had slightly reduced positive beliefs about kids with autism. And we think that is because most of our training focused on raising awareness to health extension workers about why it is important that these needs are addressed. So why do you need to look out for kids with developmental disorders in their community? Why do they need extra support? So we think that by training them, they have heightened awareness, but that might also have had the unintended knock-on effect that they were less positive about the outcomes of these children. And that likely also reflects the current Ethiopian reality, where most of these children can't go to school because they are systematically excluded from school, because there is no inclusive education system for them. So when there is an item that asks, do you think these children can attend school? The current reality is that they can't. So that is an unintended consequence that we'd like to address further. So I also talked about our adaptation and pre-testing and piloting of the WHO caregiver skills training, where overall the experience has been extremely positive. Caregivers really liked it. Literally everyone wanted to take part. Everyone completed the program. Facilitators are highly engaged, really want to run it. Amazing buy-in from psychiatrists who went above and beyond to supervise facilitators who have, independent of the research project, now started to run the caregiver skills training in the clinic already because they feel it's such an important program. So very positive findings overall. Caregivers who commented that the program helps in their child's development, and that the program also helps in addressing their own well-being. They feel very much supported by meeting other families who they didn't realize existed in their local community, who have very similar challenges to their own. So the program helps in creating that type of support. But we also identify several challenges that we still need to try and address. Many of the families that we identified, the kids have additional health needs. So we need to make sure that our program has a good referral to health services to make sure that those additional health services are met. Many of our caregivers have mental health difficulties themselves. Many indicated that they had contemplated suicide. So we need to make sure that those mental health needs of the parents are recognized. Some of the kids were malnourished. They need to be referred to feeding programs. So one important outcome is that the caregiver skills training program is very helpful, generally really well received, but cannot solve all problems by itself. So we need to work in wider levels of health, of education, of social care to address these problems more broadly.
Thank you for that. And I want to thank you both so much again for sharing your fascinating research with us and for the with the CRAE audience today. And we really look forward to seeing what the next 4 years will bring.
Thanks very much. It was a pleasure.
Thank you.